it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about 17-alpha hydroxylase deficiency. And going back to our pathway over here, 17-alpha hydroxylase is the enzyme that is responsible for taking some of these intermediates in the mineralocorticoid pathway and ensuring that we can continue on to the glucocorticoid pathway or the androgen pathway. So when 17-alpha hydroxylase is deficient, we then lose our bridge and we are unable to pass over from our mineralocorticoid pathway to either of these other pathways. That's going to result in decreased levels of glucocorticoid synthesis as well as decreased levels of androgen synthesis. Additionally, since we are losing this bridge and we are losing our exit from the mineralocorticoid pathway, we will have an increase in synthesis of all these mineralocorticoids, which are essentially building up behind this roadblock. And there's a little bit more nuance to it, which we'll talk about in the pathophysiology section, but this is the basic disruption that is occurring in 17-alpha hydroxylase deficiency. 17-alpha hydroxylase deficiency is autosomal recessive, and as we talked about in your pathway, this deficiency in 17-alpha hydroxylase will lead to decreased androgens and decreased glucocorticoids because we are unable to laterally transfer to these other two pathways. We are stuck in the mineralocorticoid pathway. Now, some of the nuances that I was referring to earlier within this mineralocorticoid pathway, we are going to see these decreased levels of cortisol because we're not able to get to our glucocorticoid pathway. So, of course, cortisol will be decreased. And because we have low levels of cortisol, this is going to lead to decreased negative feedback on your pituitary, leading to elevated levels of ACTH, adrenocorticotropic hormone. The increased levels of ACTH are going to lead to increased levels of 11-deoxycorticosterone. And if you look back at your pathway over here, you can see that 11-deoxycorticosterone is one of the mineralocorticoid intermediates that is within this mineralocorticoid pathway. So it's really important to remember that that is what is increased in 17-alpha hydroxylase deficiency, and that is going to be the mineralocorticoid, which is building up and leading to this finding of increased blood pressure. This increasing level of 11-deoxycorticosterone can still bind to the mineralocorticoid receptor, and when it does bind to the mineralocorticoid receptor, it exerts negative feedback on the RAS system, which leads to decreased levels of renin and subsequently decreased levels of aldosterone. And this is a really key point that I think can be confusing for a lot of students, that even though our levels of mineralocorticoids are increased, our levels of aldosterone are actually decreased because of this feedback on the RAS system that 11-deoxycorticosterone is exerting. And it is 11-deoxycorticosterone, not aldosterone, that is leading to the increased blood pressure finding in 17-alpha hydroxylase deficiency. Another important finding here, this increase in mineralocorticoids, specifically 11-deoxycorticosterone, going to lead to an increase in potassium excretion and sodium retention, just like aldosterone would. And this will lead to an overall alkalosis. So you might see a metabolic alkalosis as part of the presentation in 17-alpha hydroxylase deficiency as well. Key parts of our presentation for 17-alpha hydroxylase deficiency are going to be hypertension. We mentioned that with 11-deoxycorticosterone causing this hypertension. Hypokalemia as a result of 11-deoxycorticosterone promoting renal potassium excretion. And then all the symptoms of hypokalemia like fatigue, palpitations, muscle cramps, these can certainly be part of the presentation of 17-alpha hydroxylase deficiency as well. 17-alpha hydroxylase deficiency, because it is a syndrome of decreased androgen, is not going to have as stark of an impact on our XX patients because XX patients aren't as reliant on androgens for their sexual development to begin with. So XX patients are still going to have female external genitalia even if they have 17-alpha hydroxylase deficiency. They may have typical internal female genitalia, or they might have slightly underdeveloped internal genitalia. The most notable piece of the presentation for XX patients with 17-alpha hydroxylase deficiency is actually because our patients don't have these levels of androgens, which are important for breast budding as well as pubic hair development. You're not going to see breast or pubic hair development in XX patients with 17-alpha hydroxylase deficiency. These patients might have amenorrhea or infertility, and this is due to decreased ovulation, decreased stimulation by these androgens that can be important for the menstrual cycle in XX individuals. The presentation for XY individuals is going to be a little bit more dramatic and probably the one that you would see on step 1. So for XY individuals who have a decrease in androgen formation, this can lead to female or ambiguous external genitalia. And if you think about this, if we don't have any of our androgens, then we're going to have a really hard time making DHT. And DHT is responsible for a lot of the external virilization that occurs in XY individuals. Without it, we would see female or ambiguous external genitalia. But even if these patients are deficient in DHT, they still have their Y chromosome, which is creating anti-Müllerian hormone. And so anti-Müllerian hormone is still going to destroy the Müllerian duct in these XY individuals, leading to the destruction of any internal female genitalia, which would have been there. And that is why you would see a vagina ending in a quote unquote blind pouch for these individuals, because they're not going to have a cervix, they're not going to have a uterus. So even though you might have female appearing external genitalia due to the lack of DHT, that does not mean that you would still have a uterus and ovaries. In fact, you might have undescended testes, as this internal virilization is still somewhat able to occur. Diagnostics for an XX individual, you would still likely see female external genitalia. And if you performed an ultrasound, you might see typical female internal genitalia, or you might see slightly underdeveloped female internal genitalia, but you would not see testes, and you would not see a complete absence of female internal genitalia on ultrasound for an XX individual with 17-alpha hydroxylase deficiency. For an XY individual with 17-alpha hydroxylase deficiency, on ultrasound, you would not see any internal female genitalia, even though they may have female presenting or ambiguous external genitalia. But what you might see is undescended testes. And this is a great clue that we are talking about an XY individual. Anytime you see undescended testes, think that this patient is likely XY, even if they do have female presenting external genitalia. For the diagnostics, you might see decreased 17-hydroxyprogesterone. Remember, 17-hydroxyprogesterone is an intermediate right here that is directly synthesized by 17-alpha hydroxylase. If 17-alpha hydroxylase is not functioning or is absent, then we are not going to see as high of levels of 17-hydroxyprogesterone. This is actually a screening test used to screen for congenital adrenal hyperplasia. It's not specific to 17-alpha hydroxylase deficiency, but it is a great clue that we're talking about a disorder in this pathway. Decreased cortisol levels and decreased aldosterone levels can also be seen with this pathology. And then, as we talked about, due to the effects of increased 11-deoxycorticosterone, you would see decreased potassium, increased sodium, and then an alkalosis resulting as well. In terms of management for this condition, hydroxycortisone or glucocorticoid replacement is very common. There are certain surgical as well as hormone replacement procedures to alter the cosmetic appearance of external genitalia. These, of course, are ethically controversial if they are performed before the patient is able to decide for themselves, but they are still available and may be desired by some patients. So to quickly recap what we talked about in this video, going through our little memory aid over here, because we have a 1 in the blood pressure column, that means that we're going to have an up arrow, so we're going to see increased blood pressure and possibly hypertension and 17-alpha hydroxylase deficiency. Then because we have a 7 in the number column that would correspond to androgens, that is not a 1. We are not going to see increased androgens, and in fact, we're going to see decreased androgens in 17-alpha hydroxylase deficiency, which is what is going to be responsible for our presentation here, and that we see XX individuals who have decreased androgens might have amenorrhea or infertility, whereas XY individuals with decreased androgens may present with female or ambiguous external genitalia, but they would have a vagina ending in a blind pouch because they are still lacking the internal female organs. Additionally, important to remember that it is 11-deoxycorticosterone that is responsible for the increasing blood pressure, the decreased potassium, and the increased sodium that we see in this disorder. It is not aldosterone, as aldosterone levels are actually decreased. And then how would they ask you about this on a board-style question? Well, something they might ask you is a 13-year-old girl is brought to the pediatrician by her mother for her annual checkup. The patient has not started menses, and she is Tanner stage 1 for breast development. Physical exam reveals a vagina ending in a blind pouch without a cervix. Ultrasound reveals undescended testes. What would you expect the levels of aldosterone and renin to be in this patient? Okay, so this patient is a 13-year-old girl, but she's presenting to the office, and then on ultrasound, we see undescended testes. Remember, anytime you see undescended testes in a patient, it is a pretty good bet that that patient is actually XY and not XX. Consequently, we can reframe this question as an XY individual presenting with female or ambiguous external genitalia, as well as a vagina ending in a blind pouch and undescended testes. This is a pretty classic presentation for 17-alpha hydroxylase deficiency. And of course, if this patient is an XY individual, it would make sense why this 13-year-old is not menstruating, they don't have a uterus, and also is not having breastbud development because they are not XX. The question goes on to ask us about what we would expect the levels of aldosterone or renin to be in this patient. And because of the 17-alpha hydroxylase deficiency, we know that even though this patient has increased blood pressure, this is not due to elevated levels of aldosterone. Levels of aldosterone are actually decreased, as well as levels of renin are also decreased due to the effects of 11-deoxycorticosterone on the mineralocorticoid receptor. That's all I have for you on 17-alpha hydroxylase deficiency. I hope this video was helpful, and I'll see you next time.